The University of Tennessee Science Forum hosted a presentation Friday afternoon that focused on correcting misconceptions and identifying the root of the current opioid epidemic. Dr. James Choo is a pain specialist at Pain Consultants of East Tennessee. He says the current conversation about the opioid epidemic is missing the mark.
I think that we just need to get the narrative correct, that it's not just an issue of substances alone, that we've got a deeper problem of trauma, and we need to start putting our resources in that direction, and hopefully this will help with a lot of health outcomes, not just substance abuse.
Throughout his presentation, Dr. Choo explained how traumatic life events during childhood can increase the risk of future substance abuse. He also emphasized that the larger opioid epidemic isn't just an opioid problem, but rather a nationwide problem of multi-substance abuse that is fed by some legal substances, such as alcohol and nicotine. The stakes are high with this problem. In 2017, over 72,000 Americans died from opioid-related causes. For Dr. Choo, it's about better conversation rather than legislation. With experts like him guiding the way, perhaps we'll soon see the light at the end of the opioid tunnel.
Oh, thank you. Yeah, absolutely. It's good to be here. Talked with you guys. This is one of these subjects and conversations that is on everyone's minds. It's, President Obama a year or two ago opened up his State of the Union address talking about this. I mean, we're going through a change in the governor right now, and it's Bill Lee's, one of his top agendas to address this. We see it in the media every single day. We have death counts that we look at. It's one of those things that's not going away anytime soon. And we just so happen to be in a hotbed of issues and problems here in East Tennessee. Appalachia in particular has been hard hit with this opioid crisis, probably one of the leaders, if it is the leader in opioid problems in the entire country. If we look at Appalachia, we're talking about northern Georgia up through West Virginia, right through here in East Tennessee, western North Carolina. There's a particular reason for all of that. This conversation won't be talking so much about those issues. I've had some other lectures before where we talk a little bit more about why Appalachia is so hard hit. But I really want to talk mostly about all of these efforts that we're looking at, the media spotlight on these issues, how the focus on certain issues can actually lead to detriment and problems, okay? And actually, paradoxically, in trying to curb opioids, we're actually maybe doing more harm in some ways. Not saying that we were certainly overprescribing and maybe continuing to overprescribe, but this issue is so much more of a hallmark of deeper societal problems, and we're not talking about that. And we're not talking about those societal problems because, it's maybe not as sexy in the media for whatever reason to talk about some of these issues. It's oftentimes a lot easier to just couch this as one issue, an opioid problem, and it's not that. It's so much more. All right. So I'm going to talk a little bit about pain, suicides, and trauma, okay? And the reason why all of these may be interrelated in some way, shape, or form. And we need to really kind of look deeper into the problems, okay? And so we'll start out a little bit with pain. And that's my world, okay? My world, I'm a chronic pain physician. This is my life's work. And really a lot of our problems today stem from well-intentioned efforts to help with pain, okay? Our prescribed opioid problem was a well-intentioned effort to help those who were hurting, okay? And so there were federal efforts and a lot of pharmaceutical efforts. I'm not going to go into all of those, the historical whys and hows of where we are today. And I can tell you, each one of my slides, I've got 30 of them, each one could be an hour-long talk, so I can't go over in depth into all of the issues, okay? But I can gloss over what pain is at the moment. It's a sensory and emotional experience. There's a prescient description of pain by the International Association for the Study of Pain back in the late 60s that said that gave credence to this idea that pain was a sensory and emotional experience. Fast forward till maybe about 15 years ago, maybe a little bit longer than that, when we started doing fMRI work, functional MRI work of the brain, and really this beautiful explanation of pain was validated through functional MRI work. So the brain is the final organ that houses chronic pain. Okay, and so the areas in the brain, the structural areas of the brain that holds emotions and also and sensations all light up. Okay, there are areas of the brain that are that house anxiety and depression. Okay, so we see this a lot clinically in a lot of my patients, that they're depressed, they're anxious, they can no longer concentrate as well. Not only do they feel certain areas from their original injury, which also light up in those areas of the brain, but those other emotional centers are also really important part of pain, and we have to give credence to that in order to treat them appropriately. It's a disease of the brain. It is a $600 billion problem in America in medical expenses and lost wages. Okay? To put that into perspective, if we add up heart disease, diabetes, and cancer combined, it does not equal $600 billion in pain in the United States for medical expenses and lost wages. Yet we do not talk about the problems of pain in nearly the same form of fashion. To put it into perspective, we talk about the opioid epidemic. It's a $1 trillion problem for the past, since I think about 2000, okay? Well, we can, in 2 years, you do the math and see what pain costs our society in medical expenses and lost wages, okay? It's the #1 reason to access pain care, or to access health care in America. It affects maybe 25 million people if you are to categorize the pain as severe, okay? So we're talking about an enormous amount of problems associated with pain. And here's the issue, okay? So we wanted to treat pain when we tried to treat them with opioids, and today we know that that's not necessarily the best way of doing things. But you can see that the prevalence of the disease is such where it's so far widespread in America that you got to treat it some way, shape, or form. But if you treat it poorly, you're going to have some problems, right? So this is a healthy brain. It's a brain with chronic pain, okay? And as you can see, that there are some metabolic changes from one to the other. You got a lot of areas that are nice, healthy, and bright, and in the state of chronic pain, there are a lot of neuroplastic changes that really negatively impact the brain, okay? And so really, when we think about the problem with how we treat pain, it is an issue of education, okay? We like to think of this disease as that fits well within the constructs of the biopsychosocial model of treating pain, okay? So you can't just give a pill and say, all right, your pain is going to improve. All right, we've tried that experiment to the nth degree in America with opioids. We were the top prescriber of opioids in the entire world, and I don't think the pain outcomes got any better whatsoever, okay? But so why has our pain treatment failed? It's an issue of medical education. If you were to ask any physician out there today who's not trained in pain, ask all the primary care providers. I've had conferences where I've had the majority of the providers in there as primary care providers, and I've asked them, how many times have you been to a chronic pain lecture more than once? A room full of providers, I might see 1 or 2 hands raise up, and that's because we don't educate our providers on how to appropriately treat pain at all. I remember having 1 lecture at UT Memphis on opioids, and that was pretty much it when it came to my training on pain. And maybe a kind of a lecture on some of the neuroanatomy that is affected by pain, and that was about it. We're talking about maybe 2 hours at the most. And we're talking about a $600 billion problem, and we're talking about medical expenses and lost wages that are greater than some of the biggest killers of chronic disease, or biggest chronic disease players in our country right now. I have a ton of training in coronary artery disease. I have a lot of training in diabetes and some training in cancer. But had I not gone to my fellowship, I would have probably had only maybe 2 hours worth of training in pain, okay? So I think that's part of the reason why we do such a poor job treating our chronic pain patients. And these are the patients that I feel like are caught in the crossfire, okay? Because right now, yes, we've had a lot of problems with pain pill mills and overprescribing of opioids, and we probably still do, okay? And I know that we still do, okay? Tennessee was ranked number 2 in the country, always in the top 3 for some of the highest prescribers per capita in the entire country, and it all concentrated right here in East Tennessee, okay? And there were 40 plus pain clinics here in Knox County alone at the height. From here to Morristown, there were 60 to 70 pain clinics. Yeah, we had a big problem, all right, a huge problem. And so there were guidelines and efforts and insurance coverage determinations that really kind of cranked down the opioid usage, and it's worked. Okay, so now Tennessee has, for every year since maybe 2014 or 15, we have decreased the amount of pills that we have written. All right, and that's not necessarily a bad thing. I think it's actually a very good thing. However, the paradox of this decrease in opioids is that we've got more dead people than ever. Okay? Shocking. All right, so what has replaced the prescribed drugs are these fentanyl analogs, okay, and heroin that have been coming in through Detroit, maybe via Canada, maybe through Mexico. I-40 and I-75 are major highway systems right here in the heart of East Tennessee. So it's a great distribution center straight from Detroit down to this area to distribute all types of illicit drugs, okay? Prescribed drugs are controlled, so a 5 milligram Percocet is a 5 milligram Percocet, okay? With heroin and fentanyl, you have no idea what you're taking, okay? And now they're pressing pills that look identical to the 5 milligram Percocet, but it might be laced with more potent drugs. And so people that might be buying this on the street take this pill, and that's why we're seeing more deaths than we've ever seen before, in large part. So really, in the end, we're trying to capture, the addicted patient, which is fundamentally a different animal altogether than those that suffer from pain. There is some overlap, okay? I don't want to say that there are two, if this was a Venn diagram, that they did not overlap. There is definitely overlap. But we have to be very careful when we're crafting legislation saying, okay, this is just an opioid problem. Because you're going to see a little bit here from now that this is not just an opioid problem, okay? Because when we're talking about the autopsy reports in this area, okay, it's not just one drug. If this was an opioid problem, it's like, okay, this person would just had oxycodone in their system, and that's what killed them. That's hardly ever the case, okay? A lot of the autopsy reports have got benzodiazepines, antidepressants, gabapentin, muscle relaxers in their system, okay? Also alcohol. Maybe as we crank down on the number of opioid pill mills, we saw an explosion of Suboxone clinics open up all throughout East Tennessee, okay? And we were told a lot of the same stuff that we've heard from those who are makers of OxyContin, that this drug should be in the water, okay? This is not an abusable drug, that this is a drug that can help with the side effects of those who are addicted. But oddly enough, Suboxone has its own street value. There's more Suboxone in the prison systems here in Knox County than there is marijuana. And there's definitely a underground cottage industry of selling Suboxone on the streets, okay? And there was a report from the Department of Health that said, hey, what's showing up in our autopsies now are those patients, those people with Suboxone and in combination with other drugs. So it seems like every time that we've had an intervention of some sort, different unexpected problems keep on popping up. Narcan, which is the reversal agent. So basically, when you find a person down and you suspect that they've overdosed from opioids, you give them some Narcan, right? And so we've used them in record rates, right? So this is a life-saving drug here in East Tennessee. And with the record use of Narcan, we're seeing more deaths than we've ever seen before. Okay, and some of the information that I'm hearing is that they're using Narcan on the same person multiple times in a week. So what is happening is that sometimes those who are addicted, sometimes, will push their high so far up and so high to the brink of overdose, knowing full well that they've got a safety net. They get their Narcan from the emergency room or from the EMT provider and go straight back out and start hitting drugs again, because they know that they can bring it up to that kind of right on the edge, right, with that safety net. So you're talking about an incredibly motivated group, right? Death does not scare these individuals, right, for those who are really, suffering quite a bit. And now we're seeing meth and cocaine in this area exploding. And I've had conversations with the district attorney's office about what they're trying to do in the jail systems over here. And these folks who have been opioid abusers for a long, long time, they've done heroic work trying to get these folks clean. And they've had folks that have been clean for a long, long time, all right, for several months. They've had graduations and, all the kind of niceties of having a clean life for several months. And they hear in a week or two that they've got a needle stuck in this individual's arm with an IV cocaine, and they're on the brink of death. So is it really just an opioid problem when you're talking about addiction? Because we haven't even talked about the biggest killers in the United States, alcohol and tobacco. So what's going on with America? And really, honestly, if we just keep on calling it an opioid problem, we're missing the mark, because we've been seeing this entire time that this is really a polysubstance abuse issue. Okay, this is more than just one substance, and it's really, there's something else that's going on. Okay, so 72,000 people in 2017, and this number is still increasing. So this is nothing to laugh at. Okay, all right, but alcohol has 88,000 folks killed annually. That's a 30-year high. Do we talk about that in the media? And the number one killer is 450,000 people annually from nicotine. That's how many times could you fill up that stadium and with the number of folks that are killed from tobacco, right? Do we ever talk about that? No, we don't. And we have to also talk about there are other. We're talking about addiction. I'm not an addictionologist, but I've talked to those who work in the world of addiction. Food, sugar. There's there are other ways that folks can be addicted. All right. So now we need to also talk about suicides, because in the United States, there's a growing number of suicides. We are also hitting a 30-year high in suicides. All right. And how is this all linked? Okay, so if you look from 1999 to 2014, you see a gradual rise in suicides. Here in Tennessee, age-related deaths, I think suicides is number 3 in the number of deaths from the age of 10 to 24 in Tennessee, but it's also steadily rising. All right. So out of the 72,000 deaths in 2017, it is actually unclear, because the other missing part of the narrative that we're hearing is that this is just an opioid problem, that it's just pills, and you got to stop those pills because that's what's causing the issues. Well, really, it is unclear how many of those folks that have died from opioids did so intentionally. Okay? New England Journal of Medicine, after looking through a lot of data, and emergency room data in particular, I think that maybe 20 to 30% or higher were a direct result of intentional overdoses. So we really don't know. And a lot of folks that have chronic pain, chronic illnesses, have a higher risk for suicide as well. So to untease all of that data, it's really important that we start doing that, okay? And for the first time since the 1960s, the United States, these are some of the most wealthy countries in the world, and we're looking at life expectancy drop in just about every single one of those countries, except for the United States. It's the first time since the 1960s that we've had 2 years back-to-back where the life expectancy has dropped. All right, so there's something going on. Now, I believe the New York Times just reported that opioids are has killed more folks in 1 year than the height of gun violence in the United States and the height of the HIV epidemic. All right, so, but we're also not accounting for alcoholism in some of those reports, and also suicide, because really that's one of the things that we also have to think about. But those that are caught in the middle, right? If we're going to take this, and it's kind of a horrible thing to kind of wrap your head around, but if we're looking at this and quantifying it in terms of money, right? Medical expenses and lost wages. We're talking about pain patients. There's more pain patients out there than there are opioid patients or those who are addicted, right? And it costs our society more. It's pretty clear, all right? These are the folks that are caught in the middle, okay? Because with all the pain clinic regulations that are out there, there's a lot of fear. You can open up the newspapers right now and you can see those providers that are put in jail, losing their freedoms for the rest of their lives. And those that have those patients, I see it every day, are coming in saying, no one's going to treat my pain anymore. And really, in the end, if you were to do pain management correctly from the provider's end, really wouldn't have to have a discussion of opioids. The irony of it all is that we, as pain providers and those folks who have been educated in pain have known that for many, many years, as long as this problem has been going on. It's just we've never educated our providers in a comprehensive way to divorce this association of pain and opioids, all right? So, too much regulation. So, with the inception of some CDC guidelines and state guidelines, there have been some surveys that have, one in particular, that asked patients how they were doing with all of these regulations. And 40% of those patients have thought about suicide at one point in time because of the regulations. All right, so are we helping with the legislation? You know, are we helping with guidelines? Are we really doing what we wanted to do? Because if you're talking about saving lives, right, with closing down clinics, which some of them needed to be closed, you know, and guidelines and whatnot, we're not helping, guys. So if we have more deaths, if that is the end state, that is a very easily measured kind of data point. We have more deaths than we've ever had before, with more laws than we've ever had. Okay, so we've got to do it right. I won't get into my spiel about why I think some of it has been wrong and some of it has been good, in my opinion. But we just have to be careful, especially during this time where we got new leadership coming on board. I hope they really talk to some vetted leaders in this space. Okay. So, an interesting study in 2015 by Princeton, some researchers in Princeton looked at non-Hispanic whites and were looking at why people, some of the factors of why people might be dying, right? A lot of it was not just an issue of opioids, all right? It's an issue of suicides and alcoholism, okay? And this study was kind of released in and around the time of the big financial collapse. And so, you know, with the reduced labor force, reduced marriage rates, there were some potentially poor outcomes. And then there was some despair and malaise among the general population of non-whites because of some of the issues of not having the jobs and not being able to support their families in part. And really, I think these two quotes are very, very important. That non-whites, why this is important is because, you know, in Appalachia, it's predominantly non-white. non-Hispanic whites. And this is where we're struggling with the opioid crisis, that we have to really look at some of the economic forces that might be influencing this area. This is an area that's traditionally been very, that's not had a lot of resources. The education levels are lower. It's been an intergenerational problem for a long, long time. And we're seeing the consequences of some of those factors, right? And I think this is a very important statement by Deaton. We think of opioids as something that has thrown petrol on the flames and made things infinitely worse, but the underlying deep malaise would be there even without the opioids. Maybe the most important statement in my talk, okay? So if you look here, non-Hispanic whites in the United States, you can see by drugs, alcohol, and suicide, men and women the age of 50 to 54, that there's, if you compare the United States to Australia and Canada, you see where we are, right? So we're kind of delving into this kind of analysis that's a little bit deeper than, hey, it's just pills, right? We just need to control the pills and we'll control the problem. Harvard economist also agreed with some of the statements that if we're talking about resilience against some of these kind of greater forces that cause malaise and deaths of despair, we need to look at education, steady jobs, the economics of it all, right? Secure housing, food. Those are some of the factors that can build in some of the resilience that we need in our society, right? Sense of purpose, doing well financially, those things can help, right? But I think the analysis needs to go even deeper than that, all right? Because really what is also missing is the story of trauma. It's the untold story, and it's essentially in Appalachia what I believe and a lot of others believe is the common theme, okay? We need to think about things in a scientific way. We need to be evidence-based. We need to really kind of sharpen our focus on what works, okay? Because, well, let me tell you, I've heard all of the ideas that are out there, you know, moral failings, it's this, it's that, it's, you know, it's a lot of different things, but we really need to keep a critical eye on how we approach this problem, or we can make legislations, guidelines, and other things that will worsen the problem, right? I mean, it's kind of the recurring theme that I'm trying to tell everybody here. Toxic stress, we'll talk a little bit about what that means. And really, trauma, and it's quantifiable, and we've had data for 20 years on this, plus. And we'll talk about the ACE scores and how that's quantified to some degree. And the higher, it's a dose-dependent effect, the higher your stress, the higher the trauma, the worse the outcomes of your health in a lot of different measures, not just substance abuse, okay? So if you look at the adverse childhood experiences, the ACE scores, all right? There are 10 questions. It's quite simple, and actually there have been some other variations of ACE scores that ask a few more questions, but we're looking at different experiences of trauma for those under the age of 18 and its effects on that particular individual's health outcomes later on in life. It's staggering, okay? But some of the questions ask about abuse, neglect, dysfunction at the home, physical, emotional, sexual abuse, physical, emotional neglect, mental illness, whether or not a family member was incarcerated, whether a child has experienced or witnessed a mother being treated violently, substance abuse in the house, and divorce, okay? And they're simple questions. They're either yes or no in a lot of these in the ACE scores, and they're easily added up, okay? And if you look at the CDC data, all right, or, well, not the CDC data, but the CDC has looked very carefully into ACE scores and compiled the different studies that look at ACE scores and adverse health outcomes. Look at this. It's unbelievable. It's a dose-dependent dose-response curve. So the higher the trauma experienced in life, the more likely all of these things will happen, okay? Including chronic pain, okay? So that's actually one of the things I did not see in here. All right, but you're looking at alcoholism, substance abuse, there are a lot of diseases, cardiovascular disease, a whole bunch, right? So Harvard took a look at ACE scores, and the higher your ACE scores, the more likely you were more likely to have some other adverse outcomes as well, including separation and divorce, sense of hopelessness, anxiety, HIV, all of these factors, cancer even, okay? So we talked about the deaths of despair, right? We talked about the economic factors that were involved in deaths of despair, not having a good job, not being able to support your family, the stresses that would have on your life. Well, look, if your ACE score, if you say yes to more than 4 of those questions on the ACE score, you're twice as likely to be out of work, and you're half as likely to have health care as well. So it can impact your financial viability in life, your ability to be resilient, right? Tennessee and our ACE score. So happily, almost half of our Tennesseans, when surveyed, had 0 ACE scores. That's great, fantastic, okay? But we had a whole bunch that had more than 1 ACE score, over half. And we're really, really worried about this 4 and over category, right? And if you look at the ACE scores, the most common would be separation, divorce, substance abuse would be a close second, and on and on and on. So you can see what were the most common ACE scores that were studied in Tennessee or were scored in Tennessee, okay? Same thing, I think there's pretty much a prevalence of some of these, the ACE categories that were scored in Tennessee. And the outcomes in health, okay, so you're 8 times more likely to have HIV risk factors for 4+ in Tennessee. All right, and also 4 times more likely to be depressed. So we're thinking about suicides and substance abuse and other health outcomes in Tennessee. Okay, more likely to smoke, more likely to binge drink. It's pretty clear, right? And also to have poor mental and physical health, right, in the past 30 days. So not all stress is bad. We have to talk about toxic stress, what can actually effectively change your brain forever. Actually, ACE scores are showing that if you have high ACE scores at a very, very young, tender age, your brain will never be the same, okay? But there's not all, we're not talking about putting kid gloves on everybody in life, right? I mean, there is good stress, positive stress, all right? And there's stresses of life that are unavoidable, all right? So, we can talk about positive stress of exercise and, maybe an example is getting immunized at the doctor's office, tolerable stress. Life is hard. Life is tough. We need to know how to deal with it in a way. There's just some unavoidable stresses out there. It's just these stresses, the toxic stress, is what we have to really guard against, okay? And that is, we're talking about this area of life that really negatively impacts our society, all right? Neuroplastic changes of the brain, all right? This is a normal, healthy brain. When you look at toxic stress, you can see that neuroconnectivity has decreased. And I showed you that picture of the brain earlier with chronic pain, right? And the changes of the brain over time with chronic pain. It's very, very similar to toxic stress. It is toxic stress. And just something that we have to keep in mind. There's a pyramid here that talks about these adverse childhood events and how it changes the development and how we have social and cognitive impairment, risk behaviors, disease, and early death. Okay, so we really need to be cognizant of the effects of toxic stress on the lives of our children. So really, in the end, I'm kind of treading in waters that aren't my specialty, okay, when I'm talking about trauma ACE scores. And there are thought leaders out there that really deal with this on a professional basis and have used their life's work to talk about ACEs. And we're finally really in the stages in Tennessee where we're really giving credence to this idea. West Tennessee seems to be doing an admirable job at looking at ACE scores, really championing the idea of ACEs and looking at evidence-based approaches to change how kids can become more resilient in some of these harshest circumstances, okay? But really, in the end, it's, you know, some of the interventions are looking at counseling parents about not only nutrition, sleep, and discipline, but these ongoing treatments. If some of these parents are under a lot of stress and they feel like doing something harmful, they can pick up the phone at Le Bonheur and talk to a counselor online. There's some other programs that are out there, and I'm not really as familiar, but we really need to look at evidence-based approaches on how to deal with that in order to, you know, kind of keep our kids healthier for the future. One of the enemies that is out there is that a lot of times, and I've caught myself saying this multiple times, is that, well, this is just Appalachia. It is what it is. It's an intergenerational problem. There's no way that you're going to be able to fix it. People are just going to be doing the things that they're going to do. They're always going to smoke. They're going to drink, you know, and make all the wrong decisions. Fatalism, that type of attitude, is really, really, really the enemy. Because there are some approaches that are out there that other places have really looked at, and maybe even some other countries. And we need to look at all ideas, all right, on how to either treat addiction and or treat this problem of childhood trauma. All right, so there's some of the other leaders that are out there, Department of Health, some of the champions out in West Tennessee. We're at our next conference, we're going to be bringing in some thought leaders on ACE scores and their use of ACE scores in Memphis, Tennessee, and hopefully bringing some of those ideas to East Tennessee. Metro Drug Coalition has really done a great job of trying to introduce ACE scores into schools to really kind of identify those at risk. And we really need to start changing this conversation, okay? Because I've already seen the media change from, hey, this is a prescription drug epidemic. Remember hearing that? This is a prescription drug problem. You don't hear that anymore. No one really calls it that. It's an opioid crisis because now it's heroin and fentanyl. All right? But really, what we're seeing is that, and what it's always been this entire time, is that we've seen benzodiazepines, we've seen gabapentin, we've seen a host of other drugs in the autopsies of those who have died from this affliction. All right? It's been a polysubstance abuse crisis all along. You squeeze on one drug, some deadlier drugs may also pop up, meth, cocaine, you name it. And so it really brings us to this idea of, hey, we really need to look a little bit deeper. Why do people gravitate towards this stuff to begin with? And we really need to talk about childhood trauma. We really need to talk about our crisis of trauma, the epidemiology of trauma, the prevalence of trauma. We start changing the conversation to the root cause analysis of all of this, then I think we'll have a better idea of where to put our resources. All right? We need to start thinking about the brain and its resilience or lack of resilience and the conditions of which, you know, how do we promote wellness of the brain, and really be careful with our legislation, okay? Because I see it every day. I talked to a lady yesterday that said, hey, you know, I've been on opioids for a long, long time, and she's since the 80s. She's never been a misuser of opioids, and we've had to bring her meds down over the course of many years. And she's willing to do it because, you know, there are guidelines, legislation, insurance rules that require it in some cases. And she'd be the first one to tell you, look, I can understand why people would want to take an extra pill or end their life, okay, as a result, okay? So we need to get away from the stigma of really all those who are suffering from addiction and also suffering from pain. I think if we are really kind of saying, hey, this is an issue of childhood trauma, of abuse, then, you know, maybe we can go a long way of better treating this problem, okay? That's it.